Morning and good afternoon or good evening, wherever you are. Welcome to this research leader session on aging in India, emerging issues and challenges based on the longitudinal aging study of India. I don't think that I need to emphasize the importance of aging, which is forthcoming with the demographic transition, particularly the projected number of over 300 million population in India within next 20 to 30 years, which is a huge and a bigger challenges. I think it is in this context, almost 6 years back, around 2014, Ministry of Health and Family Welfare, along with the Harvard University and University of Southern California, has launched a program called National Longitudinal Aging Study of India, which is coordinated at the International Institute for Population Sciences, Mumbai, where I am currently holding the post of director. The first wave of LASI has collected data from over 72,250 individuals over age 45 years and above, and also around 31,464 elderly, which is in India, we define 60 and above. So the data has been released to the public and there has been wide interest in this data. And today what we are going to listen is primarily this information has been used and how it can be used for policy and program relevant issues to understand various dimensions of the elderly in this country. So it's my great pleasure to welcome all the speakers to this session. We have 4 papers today. One is by David Bloom, and the second one will be by Jinkook, and the third will be by Prof. T.V.Sekher, and finally Dr. Sanjay Kumar. So without wasting much of our time, let me first of all invite Professor David Bloom. He is the professor at this School of Public Health in the Harvard University, USA, to make his presentation. Can we have the presentation, please?
Good day, everyone. I'm David Bloom. I'm an economist and demographer in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. I'm also one of the 3 principal investigators of the longitudinal aging study in India, also known as LASI. I'll kick off the presentations in this session with a brief overview of LASI. I'll also say a few words about the scope and components of LASI and the major LASI milestones, timeline, and supporters. In addition, I'll go over some of the challenges we faced while fielding LASI and review some key learnings from LASI Wave 1 data. LASI is the right step at the right time for India and for making progress toward the Government of India's vision of healthy aging, as well as towards the UN vision for the Decade of Healthy Aging. As you all know, India is expected to continue its demographic transition in the coming years, which will lead to unprecedented health, social, and economic changes. It's projected that by the year 2050, around 20% of the total population of India will be aged 60 and over. That's around 32 crore people, a little less than the current population of the United States. This demographic shift presents wide-ranging and complex health, social, and economic challenges, both at present and in the future. I'm speaking about challenges related to physical and mental health, access to healthcare expenditures, physical and economic security of older adults, and changing family structures. Also, up until early this year, India had a paucity of policy-relevant high-quality data on older adults that could be used to understand the process and experience of aging and to design effective and efficient policies to promote the well-being of its older people. LASI was designed to fill this gap by providing high-quality, longitudinal, internationally harmonized data on health, social, and economic aspects of the experience of aging in India. In addition, an important objective of LASI is to make microdata available for researchers and academics in India and beyond to greatly leverage the value of the data. Let me draw some attention to 8 key features or aspects of LASI that make it a special and pioneering effort. Feature 1. The first wave, which collected data for a sample of more than 72,000 individuals aged 45 and above and their spouses, irrespective of age, is representative and well-powered at the national, state, and union territory levels, supporting cross-state and cross-national research. Feature 2. LASI offers detailed information on a host of understudied variables, including chronic health conditions, disability and assistance, life and family history, and social and economic well-being and participation in old age benefit schemes. Feature 3. The longitudinal nature of LASI will allow us to detect developments and changes in the life of older adults as they transition to older ages and to the oldest ages. It will also allow study of the influence of different interventions and context on the subsequent experience of aging. Feature 4. LASI data are reasonably harmonized to the health and retirement studies ongoing in 46 other countries around the world, allowing for rich and meaningful cross-national analysis. Feature 5. LASI includes information at the community level as well as at the household and individual levels, including urban wards as well as rural villages, which is something that has rarely, if ever, been attempted in large population surveys in India. We've received quite high response rates for all 3 sets of modules, the community, the household, and the individual modules. And that provides a solid and promising foundation for the conduct of future waves of LASI. Feature 6. LASI involved the collection of data using the method of computer-assisted personal interviewing, also known as CAPI, which is a key development for IIPS, the International Institute for Population Sciences, to move away from the traditional paper and pencil approach to data collection. CAPI also allows real-time data quality checks, which contribute to the quality of LASI data. Feature 7. Collection of dried blood spots is another great asset of LASI, which can be used to support genomic sequencing and can be assayed to provide biologic measures of health conditions that can then be correlated with phenotypic data collected as part of the survey. And feature 8, LASI microdata. LASI microdata allows for a holistic view of population aging, and it's now publicly available for the benefit of the larger scientific and policy communities in India and beyond. Now, as I've mentioned, LASI is wide and deep in its coverage of the physical, mental, social, and economic well-being of older Indians. LASI's household modules include detailed questions on household members, their housing and built environments, as well as household consumption, assets, debts, and income, and household insurance as well. LASI's individual models collect comprehensive data on respondents' demographics, health status, healthcare access and utilization, health behavior, family and social networks, work, retirement, and pension receipt. The individual schedule also includes physical biomarkers related to vision, anthropometric measurements, lung function, gait, and blood pressure. And we've also collected, as I've mentioned, dried blood spots from all consenting participants for conducting blood-based assays. In addition, the first wave of LASI includes 4 experimental individual modules on time use, vignettes, social connectedness, and future expectations. Each of these modules represents an area in which there is currently a dearth of data for older adults in India, and which may at some point be integrated into future waves of LASI as full-fledged modules to be asked of all respondents. The community module includes the collection of data on the infrastructure, facilities, amenities, and welfare schemes available for older adults at the village level in rural areas, and census enumeration blocks in urban areas. Let me now turn to some other aspects of LASI that I think deserve mention. I would start by noting here that LASI's financial support comes from a variety of sources that reflect the international nature of this undertaking. In addition to a series of R21, R01, and R03 grants, and administrative supplements as well from the US National Institute on Aging, LASI is also generously supported by funding from the Government of India's Ministry of Health and Family Welfare. LASI has also received funding support from the UNFPA, from Harvard's Weatherhead Center for International Affairs, from Harvard's T.H. Chan School of Public Health, and from several private donors. Getting us to this conference event was an exquisitely complex, deeply creative, and rather colossal effort. Under the circumstances, it seems appropriate to sketch the journey. So very briefly, I can tell you that the idea for LASI was born about 15 years ago, in late 2006, when Dr. Richard Sussman, who was then the director of the Department of Behavioral and Social Research at the US National Institute on Aging, asked me to explore the prospect of conducting a health and retirement study in India. In 2008 and 2009, we received funding from the NIA to pilot LASI and to also collect and assay the DBS, the dried blood spots that we were collecting. The LASI pilot, which was conducted in 2010 to 11, collected data from around 1,600 individuals aged 45 and above in Kerala, Karnataka, Punjab, and Rajasthan. The microdata and report for the LASI pilot are available on websites that are maintained by IIPS in Mumbai and by RAND, the RAND Corporation. In 2013, we received funding from the NIA to design and conduct the first 2 national waves of LASI. This funding was intended to cover a sample of 18,000 from India's 15 most populous states. Subsequently, the Ministry of Health and Family Welfare provided additional funding to expand the sample of LASI from 18,000 to 61,000, covering the then 35 states and union territories of India, which became 36 states and union territories when Telangana was added in 2014. In 2016, the LASI Wave 1 survey was officially launched by the Ministry of Health and Family Welfare. The launch was followed by the recruitment of state agencies, the training of trainers, and state-level trainings for field investigators and health investigators. The data collection for Wave 1 of LASI was divided into 3 phases. Data collection for the first phase of Wave 1 was initiated in April 2017. Most of the data collection was completed by the end of 2018, with only a few remaining secondary sampling units that were completed in early 2019. The currently publicly available Wave 1 microdata does not yet include data from Sikkim, as the data collection for this state was first delayed because of administrative issues and later because of the COVID-19 pandemic. The data collection for Sikkim is now complete, and an addendum will soon be released to make the data from Sikkim publicly available. On January 6, 2021, the national report on LASI Wave 1 was publicly released by the then Health Minister of India, Dr. Harsh Vardhan. And the week following that, IIPS released the microdata for Wave 1, which can be accessed from the IIPS and USC websites after completing a data request application form. It's worth mentioning that the entire LASI Wave 1 endeavor involved around 1,000 personnel, including research team at the 3 institutions, field investigators, supervisors, coordinators, field agencies, and national and international collaborators. Talking about international and international collaborators, LASI has benefited from the expertise of various organizations, including ICMR, NARI in Pune, AIMS in New Delhi, the Chest Research Foundation in Pune, 18 regional geriatric centers throughout India, numerous state agencies, the RAND Corporation in California, UCLA, and the University of Washington in Seattle. As I get to the end of my remarks, I also want to make sure that I don't whitewash some of the bumpy roads we traveled on the way here. A lot of this is, though, par for the course with a large-scale survey. For example, in 2014, because of the change in national political leadership, the research team had to reset its fundraising efforts with the government of India, which delayed the survey by almost a year. However, we're extremely thankful to the Ministry of Health and Family Welfare, as the extra time needed to secure funding from MOHFW allowed us to expand the study from our original plan to cover 18,000 individuals in India's 15 largest states to a nationally representative study covering 61,000 individuals in all 36 states and UTs, which actually ended up being more than 72,000 individuals, pushing 74,000 at this point with the addition of Sikkim data. That's due, and the bump up from 61,000 to 74,000 is mainly due to response rates that exceeded our expectations. We also face challenges in developing an instrument that is scientifically robust, reasonably harmonized with other international health and retirement studies, and simultaneously relevant to the Indian context. That translated into 3 pre-tests and quite a bit of effort to finalize the Wave 1 instrument. In addition, we face challenges in the recruitment of state agencies and in data collection because of various technical, administrative, and civil issues. The length of the LASI questionnaire, which on average took 5 hours per household with households with 2 age-eligible individuals, that was another challenge. But I must compliment the field investigators for confronting that challenge head-on and allowing us to achieve our goals. There were also delays in the release of the Wave 1 national report and the microdata because of the COVID-19 pandemic. And finally, I would mention that we are sadly at this point under great financial stress, but doing nonetheless our best to prepare to initiate the first follow-up wave of LASI in the coming calendar year. I take heart in the fact that we managed to overcome the earlier challenges, and I'm confident the pandemic will soon abate and that we'll be able to get on with LASI Wave 2. LASI is a very ambitious project, with its core values lying in the fact that the data will be made publicly available so that larger research and the larger academic community, including all of you, can take advantage of the study. So that covers the journey of LASI thus far. Let me just briefly mention some key learnings from the first wave of LASI. There are, in fact, numerous learnings from LASI Wave 1 data on the health, social, and economic aspects of aging, but in the interest of time, I will limit myself to listing 6 key learnings from those data. First, unsurprisingly, LASI Wave 1 data confirm that the prevalence of chronic diseases increases with age, as we see a higher prevalence among older adults age 60 and above compared to those in the 45 to 59-year-old age group, a higher prevalence of chronic diseases. Second, there's a considerable prevalence of undiagnosed and underdiagnosed diseases, especially hypertension, diabetes, and vision impairment. Third, non-communicable diseases are the major cause of hospitalization among older adults, yet health insurance coverage among this cohort is only around 20%. Fourth, gender differences in the health, social, and economic well-being of older adults are prominent. Some diseases, such as heart disease, stroke, diabetes, chronic lung disease, and neurological problems, are higher among men, while women are more likely to be diagnosed with hypertension, with anemia, bronchitis, depression, Alzheimer's disease and related dementias, bone or joint disease, and cancer. Fifth, the data reveal other disparities as well. Place of residence, caste, religion, education, and income seems to have considerable effects on the health and well-being of older adults. And last, a large proportion of older adults are working in the informal sector and thus are ineligible to receive a pension when they retire or stop working, which exacerbates the problem of consumption outpaying production for this group. Since the release of LASI Wave 1 data in January 2021, more than 25 papers have been published using LASI data, and many dozens more are either under review or in preparation. I'd also like to encourage all of you to please visit the IAPS and USC websites for further details on the LASI survey and to access and make use of the very rich microdata that LASI entails. This slide shows a list of some prominent LASI-related publications. I'm going to end here. Thank you all for your time. And if you have any questions, comments, or suggestions, please feel free to email me at dbloom@hsph.harvard.edu. Many thanks.
Thank you. Thank you, Professor David Bloom, for providing an overview of the journey of LASI for the last perhaps more than a decade, from the pre-testing to the current first wave, the release of the result. Unfortunately, Professor David is unavailable now because of the time differences, as you can understand. But at the same time, if you have any questions, please feel free to put it in the chat box, or you can also unmute and ask these questions during our discussion after all the presentations are over. So thank you. We will move on to the next presentation now. The next presentation is by Jinkook Lee from the University of Southern California on air pollution and cognition insights from LASI. So can we have the video, please?
Hi everyone, I'm Jinkook Lee, a professor of economics at the University of Southern California. I have developed LASI as one of 3 principal investigators of the project. Today, I will discuss new findings from LASI on the relationship between air pollution and cognition. You might have already heard about health effects of air pollution. Particularly in India, air pollution is a serious health issue. I will be discussing 2 recent work, one published and one at analysis stage, and therefore results are still preliminary, using LASI and its add-on study of late life cognition and dementia, LASI-DAT. Globally, ambient air pollution contributed to 4.1 million early deaths per year. India is one of the most polluted countries in the world. All of India's 1.3 billion residents face annual average pollution levels exceeding the WHO guidelines. On last Wednesday, November 18, 2021, the country's Supreme Court has stepped in to shut down coal-burning factories, order farmers to stop burning fields, and close schools. The New Delhi state government is even considering the idea of weekend lockdown to reduce automobile traffic and other air-polluting activities in the city. In addition, 3 billion people use biomass fuel for cooking globally, and burning of household air pollution is responsible for 2.4 million early deaths per year. In India, 46.6% of households use polluting cooking fuels. Findings regarding the effects of air pollution on human health have been established for respiratory illnesses, cardiovascular diseases, and mortality. More recent research has suggested that the negative effects of high air pollution exposure may also extend to poorer cognitive outcomes. Here we hypothesize worse cognition with two sources of air pollution. First, polluting household fuel use, and second, ambient exposures at residence. For this study, we use LASI, an ongoing cohort study of over 72,000 older adults in India. And LASI-DAT, an in-depth nationally representative study of late life cognition and dementia in the country, we administered a very detailed cognitive test battery, which is called Harmonized Cognitive Assessment Protocol, to a subsample of over 4,000 LASI respondents aged 60 and older from 18 states and union territories. We measured both exposure to household air pollution and ambient air pollution. We identify household exposure to indoor air pollution by asking a series of questions about main sources of cooking and heating fuel with sufficient details such as types of stoves, household use, ventilation, and exposure to other sources of indoor air pollution. For ambient air pollution, we estimated exposure to PM2.5 by calibrating satellite data with data from ground monitors and matched those estimates with each household using geographic information. This model, called Data Integration Model for Air Quality, was developed by my colleague, Dr. Gavin Sheddick. This calibration model has been used by WHO and Global Burden of Disease projects to estimate global burden of air pollution. Using Bayesian hierarchical model, Gavin's team calibrated the data from ground monitors with satellite, remote sensing, chemical transport models, and other relevant information such as land use, load patterns, and altitude. We have estimated the annual average exposure to PM2.5 at 1 kilometer by 1 kilometer for years 2010 to 2016. Here is the 2016 map of India showing the annual exposure to PM2.5 at 1 kilometer by 1 kilometer level across the country. You can see significant geographic variations. As I noted earlier, we matched this estimate to each household using GPS information. To study the effects on cognition, we administered a battery of cognitive tests. For LASI, the battery is brief, about 15-minute version, but for LASI-DAT, we administered an extensive 1-hour battery of cognitive tests covering various domains of attention, language, visuospatial, learning and memory, judgment and problem solving, and executive functioning. My colleague, Dr. Alden Gross at Johns Hopkins University, constructed latent variable of cognition, and we used this overall underlying cognitive ability as our outcome variable. Using this overall cognition variable, we first examined the taxing effects of household air pollution on cognition. We found that individuals living in households using polluting fuels have worse cognition than the individuals living in households using clean fuels. Even after controlling for key covariates, such as socioeconomic status like education and household consumption and wealth, and urbanicity, there is significant air pollution effect. We found strong and significant effect on cognition, showing exposure to polluting fuel is equivalent of about 6 years of cognitive aging. This is a collaborative work with my colleagues, Dr. Seradar, Aparajita Chattopadhyay, Jenny Wilkins. Our team also found the consistent effect in Mexico and China using comparable data on air pollution and cognition. As noted earlier, we, the LASI team, collected detailed information about ventilation. We found that airflow matters. Individuals living in households with no ventilation were exposed to greater more exposure to air pollution and see much greater negative effect, but this harmful effect gets reduced if there is a chimney or windows or doors. We also found newer cooking technology could really help. When we compare different types of stoves, this result gives me a sense of optimism. New stove can help even though we cannot immediately change the type of cooking fuel the household use every day. Now, here is the results of our analysis of ambient air pollution together with household air pollution. After controlling for a comprehensive set of risk factors, we found strong and negative effects of air pollution, both polluting cooking fuel as well as exposure to ambient air pollution. We are at a very beginning stage of this analysis, and in this model, we are looking at mean average of ambient air pollution over 7 years, but we can further refine this model. Together with our earlier published work on Environment International, we confidently conclude that cognition is lower with biomass household fuel. We also found suggestive early results that cognition is lower with higher ambient exposures. We think there might be differences by emission sources and started looking into this difference as well. Here you can see exposure to air pollution by different emission sources. You can notice significant geographic variations in these emission sources. With further work, we will be able to provide further insights to policy-relevant questions. I want to conclude my talk with my sincere appreciation to my colleagues, funders, and all of you who listened to my talk today. Thank you.
Thank you, Jinkook, for providing an understanding of the relationship between air pollution and cognition. I think she has also told us various studies which has dealt with this relationship and the importance of air pollution, the problems with air pollution on various aspects of health and particularly on the cognition. So unfortunately, Jinkook Lee is also not able to present today because of the time zone differences, but at the same time, we will be happy to take up questions and she will be able to answer either through email or other collaborators of the LASI project who are present here will be able to answer those questions. So now we will move on to the next presentation. Next presentation is by one of the another principal investigators of this project, LASI, Professor T.V.Sekher, on social security programs for elderly in India. So can we have the video, please?
Hello, everyone. This is T.V.Sekher, Professor of Demography and Sociology at the International Institute for Population Sciences, Mumbai. I am also one of the principal investigators of longitudinal aging study in India, LASI. Today I am going to discuss the social security programs for elderly in India, an assessment based on the first wave of longitudinal aging study in India, LASI, which was carried out in 2017 and 2018, covering 72,000 older adults across all states and union territories in India. Before getting to the social security schemes, it is better to have some idea about the important characteristics of India's elderly population. As you can see here, nearly 36% of the elderly are continue to work even after 60 years of age. This is more in the rural areas, mostly in the informal sector, particularly in agriculture. There are more elderly working, and also those belong to the deprived and marginalized communities. The work participation rate is quite high. They are working not for the sake of work, but they are forced to work to support themselves and their families. And if you look at another important characteristics of India's elderly, according to the LASI survey, 18% of the elderly are only covered by any health insurance schemes. So it is a formidable challenge for the elderly and their households to meet any medical expenses for their treatment. Now, in LASI, we asked a question about the extent of financial support received and provided by elderly during the last 1 year. As you can see, 15% of the elderly received the financial support from their relatives and friends, whereas only 6% of the elderly were able to provide financial support to others during the last 1 year. Now, when we discuss about the social security schemes, the most important program in India is the old age pension scheme, known as Indira Gandhi National Old Age Pension Scheme. And the pension amount varies considerably across the states. And those who are above the 60 years of age and belong to the poor or BPL households, below poverty line households, are eligible to receive an old age pension. And it varies from state to state, starting with $5 in some states, equivalent Indian rupee, to $15 equivalent Indian rupee in some states. This is a monthly pension given to the poor and destitute elderly. And in some states, there is an additional or enhanced payment of pension those who are above 80 years of age. And this also varies from state to state. And it is, if you put it into the US dollar terms, it is starting with around $7 to, in some states, it is around $40 per month. So this is the scenario with regard to the old age pension. And even the widow pension is also, the amount given is more or less similar in each of these states. Now, we asked a question about the awareness of old age pension scheme and widow pension scheme among our respondents, elderly respondents. At the national level, only 55% of the elderly are aware about old age pension. And when it comes to widow pension, it is even less, only 44%. But there are considerable differences across the states and union territories of India. Now, how many are actually the beneficiaries of these pension schemes? Considering the old age pension scheme, nearly 22% of the elderly belong to the BPL households who are eligible to get pension. Among them, 22% are currently receiving the old age pension. With regard to the widow pension, it is only 19% of the widows belong to the poor households are currently the recipients of widow pension scheme. This is the national average, but there are significant variation across the states. Now, awareness and utilization of old age and widow pension schemes are higher surprisingly in rural areas. More than half of the elderly are aware about old age pension scheme and 44% are only aware about widow pension scheme. 1/3 of rural elderly belong to the BPL households receiving old age pension. And 25% of the rural elderly of the BPL households are also recipients of the widow pension scheme. There is another scheme called Annapurna scheme, which provide free food grains through public distribution system like wheat and rice to the poor and destitute. Its awareness as well as utilization is abysmally low. Now, LASI probed about those who are not availing the social security schemes. What are the reasons for not availing them? Nearly 35% of both men and women said that in order to avail the old age pension, the process of getting the benefit is very cumbersome. And that is true for 20% of the cases of those who want to avail the widow pension scheme. And getting the documents and procedural completion of various formalities also taking a lot of delay. It is also important to note here that at a time, the elderly are eligible to receive only one pension. Those who are receiving the widow pension, they are not eligible to receive the old age pension. Now, even among those who are currently receiving the old age pension and widow pension, we further asked what are the problems usually they face. 30% of the beneficiaries of old age pension stated that there was considerable delay in receiving the money. Sometimes instead of getting every month, they get the pension in a bit once in 3 months or once in 4 months. Nearly 1/4 of the elderly also reported experiencing problems in producing the required documents to continue the pension from time to time. Similar is also the case with the beneficiaries of the widow pension scheme. Now, Government of India provides, as well as the state governments, various concessions to the senior citizens for elderly people. This includes travel concessions, concessions with regard to the bank loans and interest rates, concessions with regard to the income tax payment and many other things. So about a quarter of rural elderly and nearly 37% of the urban elderly are aware of concessions provided by the government. And it's, as expected, it's relatively higher among the elderly men compared to the elderly women. Now, these are the type of percentage of elderly who availed various concessions given to the senior citizens. Train travel and bus travel are availed by a good number of the elderly, and the air travel is a small percentage of elderly. Nearly 2% of the elderly are benefits of the special interest rates on bank accounts and bank loans, and nearly 2% of them are also benefiting from income tax rebate. So the proportion of elderly who utilize various types of concessions given by the government is rather low. 15% of elderly have benefited from the concessions for train and bus travel, whereas only 2% of the elderly utilize concessions for air travel. And 3% of the percent of elderly benefit from special interest rates of the banks. But we have to keep in mind, most of these beneficiaries are the urban elderly. Now, in 2007, Indian Parliament passed a landmark legislation known as Maintenance and Welfare of Parents and Senior Citizens Act. As per this act, it is mandatory for the children to look after their parents, and it is punishable for the children to abandon their parents. And even the act has a provision, even after inheriting the land, house, or any property of the elderly, if the children are not looking after them, then there is a provision in the act to revert back the property and asset back to the elderly citizen. But even after 15 years after the enactment of this legislation, according to our survey, we found that only 12% of the elderly are aware of this act. And of course, it is slightly higher in the urban areas. So it also needs to show that we need to create more awareness about various provisions, various legislations enacted for the welfare and protection of elderly in India through the elderly helplines, senior citizens associations, and through the local self-governments and voluntary organizations. So broadly speaking, what we see is the social security measures for elderly on the whole is inadequate, and it caters only to a small segment of the needy population. There is a growing need for interventions mainly to ensure income security for the elderly and to create a coherent policy to meet their needs. Governmental attempt to target the pensions to poor and destitute elderly was not very effective. We found many elderly belonging to the non-poor households were also recipient of these pension benefits. Government should also enable active involvement of civil society groups and private sector organizations to create a more elder-friendly attitude and to facilitate to meet these major challenges. So more focused attention is required through policy and program interventions, considering the increasing vulnerability of elderly, particularly the elderly women. And Indian context, large number of them are widows living in rural areas. They are the most vulnerable segment among the elderly population. And the next 2 to 3 decades, India is going to experience a drastic increase in the elderly population. According to the projections, by 2050, country will have around 20% of its population as the elderly. That will be approximately 320 million elderly in India by 2050. So this is going to be a major challenge for the households, societies, and the government to provide the basic social security support for the growing elderly population in India. If you want to know more about the LASI and LASI findings, you can download the LASI India reports and fact sheets for all the states and union territories from our website. LASI data is also available in public domain free of cost. You can apply for that. And if you have any other questions, please write to us. We will be very happy to answer your queries and questions. Thank you very much.
Thank you, Professor Sekher, giving an overview of the social security measures in India and its issues, especially in the context of an informal sector workers in this country without any pension. Professor T.V.Sekher is available with us, so please feel free to ask any questions. You can type either in chat box or you can ask these questions at the end of all presentation by unmuting yourself. So we will move on to the last presentation today. Last presentation will be by Dr. Sanjay Kumar from the UNFPA India. So Dr. Sanjay Kumar will be speaking on public health care utilization by elderly in India. Over to Sanjay Kumar. Can we have the video, please?
Good afternoon. Many thanks to RUSSP and in particular IIPS for inviting us to present our work on public healthcare utilization by elderly in India, an analysis of major determinants. As we know, aging is one of the prominent emerging population issue. It has also started surfacing in developing countries, and the concerns are that the speed of aging will be much faster in these countries as compared to whatever has been experienced in the developed nations. In India, the number and proportion of older person is also increasing, and it is expected that by 2030 we will have around 193 million persons aged 60 years or above, which will be around 13% of the total population of the country. And at age 60, the older persons are expected to live longer and for about another 18 years as of now. So therefore, it is important to ensure that they not merely live longer, but they are also able to lead a healthy life. The studies indicate that in India, around 65% of the elderly, they suffer from one or the other chronic morbidities. And we also know that because of the lack of credible health insurance system, most of the time, either the elderly or their family has to bear out-of-pocket expenses for the healthcare needs. Recent studies have also indicated that only 1/3 of these elderly utilize healthcare system from the public facilities, which is almost free of cost. In future, the demand for healthcare of the elderly is expected to increase because of the increasing size of the elderly. So therefore, it is very important that utilization of public healthcare system will be very critical for ensuring better living standard of the elderly in India. With this backdrop, the main objective of this study is to investigate determining factors which distinguishes availing services from a public health versus private health sector in India. Among those older persons who have utilized healthcare services in the recent past. The paper analyzes data from Longitudinal Aging Survey in India, which is a nationally and state representative study of aging and health. I will not go in detail about this survey because this has already been explained in this particular session. In our paper, the analysis is based on the responses of around 17,000 elderly who had availed outpatient services from any type of facilities in the last 12 months prior to the survey. We used binomial logistic regression analysis to study the log odds of availing outpatient services from a public health facility. We also found that around 14% of the elderly had sought services from a facility which is run by either NGO or by a trust, which is largely free of cost. So hence this was merged with the government facilities in our analysis to create a dichotomous variable with 0 for private facilities and 1 for either government, NGO or run by trust health facilities. The predictors included in the model are the place of residence, the age category of the elderly, their sex, their living arrangement, either they are living alone or they are living with children, family or others, their marital status, religion, caste, monthly per capita expenditure quantiles into 5 categories, whether they are currently working or receiving pension from their previous job or receiving benefits from any of the social security schemes, distance from the health facility, and whether they are covered with the insurance scheme or not. The findings indicate that more than half of the elderly in India, around 59%, had utilized outpatient services during the 12 months prior to the survey in LASI. We also found that majority, around 2/3, which is 63%, they have sought services from a private facilities or a provider, while only 30%, 37% had availed public health systems. And bivariate analysis indicated that the group of elderly which are more likely to get services from the private facilities are those who are currently married or living in urban areas or living with either spouse or children, belonging to other than Hindu or Muslim religions, and belonging to scheduled caste and scheduled tribe castes, and holding any insurance policy. In order to assess the net association of the background characteristics of the elderly, we undertook multivariate analysis and controlled all other variables included in the model. The value of odds ratio greater than 1 in the model shows that elderly are more likely that they will utilize the health services from a public health facility, and odd ratio of less than 1 shows more likely of utilizing private facilities for outpatient care. The results of the multivariate analysis clearly shows that there is a group of elderly who are more likely to avail outpatient care from the public health facilities, and these are younger category of the elderly, those who are living alone, or those who are not currently married, either they are widowed or separated, or they belong to Muslim religion, or they belong to SC or ST caste category, and whether all those elderly, those who are receiving any social protection scheme from the government, they are more likely to avail health facilities from the public sector. So these are the group of socio-demographic factors which distinguishes these elderly for availing health services from a public health facilities. On the other hand, as expected, the economic factor has a negative association with availing public health services. Older persons from every higher category of monthly per capita expenditure quantiles, what we found that they are more likely to utilize private facilities or a provider for healthcare needs. Those elderly holding any insurance policy and living in urban areas are more likely to avail health facilities. One of the important and interesting findings was the distance of the health facilities, which suggests that the older person prefer to go to private facilities, even those which are at a far distance from their place of residence. And this might be because of the better quality of care as perceived by them, or maybe a better quality of services being offered into the private healthcare facilities. So with this, the conclusions and way forwards are that the study has actually clearly identifies a vulnerable segments of elderly population who are more likely to dependent on public health systems, and this may be mainly because of the affordability issue. We also know that the government of India's flagship program, which is known as Ayushman Bharat, is an attempt to provide healthcare services to the vulnerable and marginalized population segments, including elderly persons, but this particular program is more focused and is mainly for hospitalization care and specialized care for which insurance is provided by the state. The need of the hour is to design and implement programs for easy access of the public healthcare systems, both for hospitalization and also for outpatient services for the vulnerable segment of the elderly. So probably this is the time we could suggest to have an added component in Ayushman Bharat to provide healthcare facilities for those who are going for outpatient care. The finding also suggests, based on the distance of the facility, that despite public facilities in their close proximity of those elderly persons, even they are likely to avail services from the private facilities. This suggests to pay attention not only the availability and accessibility of services at lower public health facilities, that is primary healthcare center, but also to pay attention on the quality of those services at the lower level of health facilities in the country for the healthcare needs of the elderly. Thank you for your kind attention.
Thank you. Thank you, Dr. Sanjay Kumar. I think that ends all the presentation of this session. We will have time for suggestions, for your comments, as well as any questions. If you really want to ask, you can either put it in the chat box or please feel free to unmute and ask questions, because of we have made everyone as participants. So naturally, all of you are in a position to unmute yourself and ask questions. As all of you know, we had 4 presentations. First was primarily on the background of the LASI. I think all of you, many of you may be aware, but at the same time, it gives you an overview of what was the motivation, how it was been structured, how these instruments has been made, and then what was the first wave of the LASI study tells in terms of the major findings. Professor David Bloom has presented on that. The second presentation was primarily looking at the causal linkages between air pollution and cognition, and the studies found that there is a closer linkages. So air pollution is something which we need to address, especially the household air pollution, which also constitute a significant proportion of the total pollution. That is what the study has found. The last 2 presentations was actually touching upon the major important aspects of the elder care in India. As you are aware, one is the social security system, because being an informal sector, being not having pension system, a full developed pension system, naturally the social security programs become very, very important for the sustenance and for the well-being of the elderly in this country. And Professor Sekher has presented various aspects of the problems of administering social security system and its limited coverage, and also the problems. But it has also the other aspects, because there has always been a discussion on the fiscal sustainability of it from the other macro side, whether how far it is possible for a low tax base country to provide social security and how far it can be extended. I think all those issues are very, very important for the country, particularly when we are moving from a large proportion of elderly in coming years with a faster demographic transition. And most likely that children will also migrate because their aspirations are high, they are educated, and they will also migrate to get better jobs. So naturally, it is possible that the parents are not taken care of fully. The second major aspects of the elder care is the health care of the elderly, and especially the hospitalization part, which Dr. Sanjay Kumar has emphasized. And he has looked at the role of public sector in this and how it can be enhanced. It has several policy relevance. I'm sure you may have some interesting questions to ask. Please feel free to unmute and ask questions. In between, I will also be looking at the chat box. And in case there are any questions, I will also address this to the respective authors. In case you have any questions specifically for David Bloom and Jinkook Lee, please feel free to type it in the chat box. We will convey those questions to them, and they may be able to reply you over email, or in case you can provide your email ID as well. Thank you. And in case there are any questions, please you can raise your hands, and so that I can invite you to ask questions. In the meantime, there is a question to Professor T.V.Sekher. Sekher, how do you explain so few elderly, even in socially conscious state like Kerala, do not avail themselves of pension benefits? So, in case you have anything to suggest, please.
Thank you, Dr. Gilmotto, for this question. This is true not only for Kerala, even many other states. We have to keep 2-3 things in mind. One is that if you look at only the old age pension, there are also many elderly who are receiving the widow pension as such. As I mentioned in my presentation, at a time they can receive only one pension. So we have to keep both this together to see that how many of them are actually receiving it. Okay, even then their coverage is quite low. At the national average, it is only 1/4 of the elderly are receiving the old age pension, and another 1/5 are among the women receiving the widow pension. There is also an issue which I mentioned in the presentation. The analysis was basically those who belong to the BPL households among them. But there are our survey and the earlier surveys like the UNFPA sponsored BKPAI survey also indicated that good number of elderly belong to the non-PPL households also are recipient of many of these pension benefits. So that is one issue also need to be discussed, and the amount also varies considerably across the states. Something like 300 to 400 Indian rupees in some states to 2,000 in some other states. So the amount contributed by state government makes the big difference. In a state like Kerala, it is around 2,000 rupees, but in a state like Bihar, it is only 400 rupees in a month. So there are a lot of issues involved with the pension schemes, both for the elderly and also the elderly widows.
Okay, thank you. And anyone would like to ask questions, please.
I have a question to Dr. Sanjay. Can I?
Please, please.
Yeah. Sanjay, that was an interesting presentation. Just I want to ask you, the older people availing the service at the private facilities, you mentioned the quality care issues at the public facilities, that is fine. What about the waiting time at the private facility, public facilities, particularly for the older people? Not many of these public facilities have geriatric care centers or specialized medical officers to look at the older people. That is one. And then the other thing is also, I think the LASI has collected information on the expenditure also. If the people are availing private facilities, either as outpatients or for hospitalization, the cost of utilizing these private facilities, if the naturally the private facility cost is much higher, how to explain it? Even the but the data also, other types of data also show that the elderly people are working for working for their livelihood, but still some are using the private facilities. How to explain this?
Can I come to answer that? Okay.
Yeah, please.
Thanks, Subramaniam, for a very good question. There are two parts of it. First, you say about the quality of care and something. So we thought that as a might be perceived quality of care, and probably one needs to also quantify, which we have not done in this paper. Your other point is a very valid one, is waiting time in health facilities. I'm not sure whether this data is available or not. And if it is there, so probably one can look into, and probably that could be, help us to understand the quality of care into this particular model, and then explain why people are going to private versus public. The second part on the expenditure aspect, yes, expenditure data is available in the data set. And as you have rightly said, it is a bit higher for those who are availing either hospitalization or outpatient care from the private. We purposely didn't want to put that one into the model. The reason being is that, obviously when you go to so your decision first comes, whether are you able to afford it or something, and then you go and spend that much money. But here the purpose was to understand which are the group of people, even after controlling for if they have there's some disposable income like working or receiving pension, so that we put into the model. So that's why we did keep into that expenditure part. However, I think further if we can do more analysis that to come up with the policy implications, that how much more these elderlies are paying while going to private, and how much out of the pocket expenditure can be saved by them. Probably we can look into that matter, and it will strengthen our evidence-based research for policy advocacy. Thank you.
Thank you. Thank you, Sanjay. I think the question always has been discussed was whether actually the out-of-pocket expenditure, even in a public health facility, is significant. That is, many studies have also found that there is significant expenditure, even if although we say it is free, but there are expenditures relating to accessing public health facilities. So anyone who is looking for whether to access public or private will also compare what are the expected expenditures between these two facilities. That becomes very, very important. Okay, I think there are another question to Sanjay. What is the satisfaction level of elderly while using public health facilities compared to using private health facilities? Or
So
satisfaction for using public health facilities.
Okay, so actually is a good point, but in our paper, since it was out of the scope to understand those satisfaction, but we can look back to the data set and find out which are the variables which is available to understand, or to measure the satisfaction level of those using either private or public facilities, and along with, as what Professor James was telling, is how much cost and something is there. So that will be an additional part we can look into. But as of now, we have not looked into it. But thanks for raising this point.
May I ask some question?
Yes, please. Yeah.
Sir, I want to know that is that the social security system for elderly covers the social networking and the social support or instrumental care for elderly. And my second question is that, sir, in LASI questionnaire, if we see that the LASI questionnaire, there is different segments of the like social network, family network, and the social support. So if you want to make an indicator in Indian perspective, so what will be the appropriate method to measure that social networking and the social support? Thank you, sir.
Okay, thank you. Over to Professor Sekher.
Yeah. In LASI, of course, apart from social security schemes, we have a big section on the family and social network. as you rightly said, we have a lot of questions on elderly social participation, elderly involved in the instrumental caregiving, care receiving. We also have a lot of questions on their civic participation. We also have the questions related to how many of them are financially contributing to the household. So, lot of questions related to that. So, it depends upon what kind of index you want to develop. I think there is enough scope for doing or computing an index using all this information available for these individuals and also for their households. So it depends upon what exactly you want to look at. Even we have some questions about how closely they are involved with other family members. The elderly's involvement in the household decision making. Lot of information is collected, and some of the things are also already mentioned in the India report. And also, you can look at the questionnaire and the data set and decide on what kind of indicators you want to choose to develop your own index of social networking or social participation or social cohesion. Thank you.
Thank you, sir.
Thank you. Any other questions? If there are no other questions, we will come to the end of this session on aging in India, particularly looking at the emerging issues in the context of LASI data, particularly published on Wave 1. Thank you all for your participation. I'm sure you have enjoyed the session. And in case you have any further questions or suggestions or comments, please feel free to write to the email which has been shown in the slide, which has been presented by both David Bloom as well as by Professor T.V.Sekher. So you can write directly to LASI email, and also the entire data sets, the instruments, everything is available also in the website. So thank you for your participation and have a great day ahead. So we will close this session for today. Thank you.
Thank you, Prof.
Bye-bye. Thank you. Bye-bye.
Thanks. Bye-bye.